Scott Brown's Otology, Chapter 85, Ossiculoplasty, Classification of Defects. Classification of defects. The value of a classification system is to enable systematic description of preoperative ossicular status to facilitate meaningful analysis of surgical outcomes given the multitude of surgical approaches for correcting ossicular chain abnormalities. It is essential when evaluating the results that the pathologies are comparable. While each patient will present a subtle, unique anatomical situation, defects can be broadly characterized by the presence or absence of different components of the ossicular chain. The most widely used classification system is the Austin-Kartosh classification, which applies to situations without an intact incus. First proposed by Austin in 1971. Four distinct anatomical situations are described in Table 85.2. Table 85.2 Ossicular chain defects in 12-11 consecutive chronic middle ear cases. Defects: ossicular chain intact. Incidence with cholesteatoma n equal to 692. Percentage of incidence without cholesteatoma n equal to 519. Ossicular chain intact 2771. Incus alone eroded 2618. Incus and stapes eroded, malleus intact 24-7. Incus, stapes and malleus eroded 11-2. Incus, malleus eroded, stapes intact 8-2. Stapes alone eroded 2.4. Table 85.3 Modifications to classification system. O. Intact ossicular chain. E. Ossicular head fixation. F. Stapes fixation. Table 85.5 Middle ear risk index 2001. Otologic factors: maximum score, Otorrhea 3, perforation 1, cholesteatoma 1, 2, ossicular status 4, middle ear granulation 2, previous surgery 2, smoking 2. Austin classification of ossicular chain defects with absent incus. Groups A, B, C, D and ossicular chain status, abbreviation and prevalence percentage. Group A, malleus handle and stapes superstructure present, M plus S plus 60%. B, malleus handle present, stapes superstructure absent, M plus S minus 23. C, malleus handle absent, stapes superstructure present, M minus S plus 8. D, malleus handle and stapes superstructure absent, N minus S minus 8. Below see classification of Otorrhea. Otorrhea risk value: dry ear 0, occasionally wet 1, persistently wet 2, persistently wet plus cleft palate 3. Prognostic factors. The ideal scenario in which to perform ossiculoplasty is in a stable, well-ventilated middle ear with an intact tympanic membrane in the absence of ongoing middle ear infection or cholesteatoma. Absence of any of the above factors increases the risk of failure, as do patient factors such as smoking status. The Middle Ear Risk Index MERI was devised by Kartosh in 1994 and generates a numeric value which corresponds to severity of disease and the likelihood of successful outcome following surgery. This can be used to guide case selection and counseling of patients preoperatively, but is perhaps most useful for research purposes. It is an amalgamation of the Austin-Kartosh classification of ossicular defects, the Belosi classification of Otorrhea, and takes into consideration the presence of tympanic membrane perforation, middle ear granulation, and cholesteatoma. The MERI was originally scored 0 to 12 and was later modified in 2001 to include smoking and increase the weighing for granulation and cholesteatoma, thus giving score of 0 to 16. Alternative risk stratification or scoring systems include ossiculoplasty, outcome parameter, staging, OOPS index, or SPITE, SPITE factors, surgical prosthetic infection, tissue, use ratio. Key points. Used for classification systems such as the Austin-Cartouche classification allows a meaningful analysis of results and comparison of results between surgeons. Ossiculoplasty results are significantly affected by the status of the middle ear. Materials for reconstruction. The ideal materials for ossicular reconstruction should be biologically stable, resistant to resorption, and non-reactive. Of the correct mass and stiffness, be easy to handle, and ideally low cost. There are many options for reconstruction which can be broadly divided into autografts, homografts, and alloplastic materials. Autografts are tissues that are harvested from the same patient on which they are used to be used and can include ossicles, cortical bone, and cartilage. Their primary advantage is excellent biocompatibility with low risk of extrusion. When available, an autograft offers a low-cost solution compared to ossicular prosthesis. Incus interposition is an example of a well-described and popular technique in situations with an intact malleus handle and stapy superstructure. Cartilage tends to be less stable due to displacement or resorption and is less commonly used. Limitations to the use of autologous ossicles are that the incus is not uniformly present in deceased ear. While technical skill and time are required to sculpt the incus to the required shape, there is a risk of implanting residual disease if the ossicle has been enveloped in colostoma. Therefore, careful assessment of the integrity is required. Some surgeons recommend autoclaving ossicles prior to the reimplantation to reduce the risk of residual disease, but this is now not widely practiced. Homograft. Homograft material is derived from human donor tissue.